My guest today is Dr. Alexander Y. Walley, M.D. and Master of Science. He's an associate professor of medicine at Boston University School of Medicine. He is the director of the Boston Medical Center Addiction Medicine Fellowship Program. His research focus is on the medical complications of substance use, specifically HIV and overdose, and he is an active investigator on clinical trials and cohort studies. He provides primary care and office-based addiction treatment for patients with HIV at Boston Medical Center and methadone maintenance treatment at healthcare resource centers. He is the medical director for the Massachusetts Department of Public Health's Opioid Overdose Prevention Pilot Program. Welcome, Alex.
Thanks, Bill. Happy to be here.
Let me, this may be an offbeat sort of question to start with, but after everything I read, and I've read your CV, I could take the whole program and just read your CV. It'd take that long. Do you have any free time?
Sure.
And
Try not to work after 5:30 if I can. I watch a lot of TV with my wife at home. I like to swim. Yeah, and I try to take it easy on the weekends.
Good. What are you? Just curious. What are you watching right now?
Right now, I'm watching a French spy series called The Bureau.
Oh, okay. You're not watching The Pit, I trust.
I watched one episode. It's on our list. I really liked it, actually. I
Yeah.
was a big ER fan in the 1990s, and Noah Wyle is the lead actor in that, one of the lead actors in that show.
He's very good.
Very good. And yeah, I just watched the first episode. There were some flashbacks to COVID, which I thought were very poignant, and I'm kind of interested to see how that develops in this series.
Yeah. Well, I've watched, or my wife and I've watched a little more than you have, but I'm not going to give anything away.
Okay.
Well, we met to be precise, April 4th, 2014. And we were on the same panel, I guess you'd call it, about you were an invited presenter on preventing the opioid overdose with education. And I guess I got that right. I'm not doing very well. And we were there to discuss our son had died 2 years ago. It was the first time we had a chance to tell our story. And I'm just wondering if you'll allow me, I want to read a little bit of what I wrote because it applies to you. And I hope we can make the connection here. At the time, we were talking about parity, which is insurance parity, but I wrote, parity is when physicians, not health insurers, practice addiction medicine, when physicians, not actuaries, determine the best course of treatment. Parity means that people with substance use disorder are treated with the same compassion and understanding, treated with the same urgency, accorded the same dignity as any other patient with any other medical or surgical need. Parity is when physicians are trained to recognize and treat substance use disorder in medical school with the same rigor given to any other disease. Parity will be when physicians in any specialty can recognize, treat, or refer patients to a proper source of treatment. Parity will be when there are sufficient numbers of physicians board certified in addiction medicine. Now, when I wrote that, and I had no idea that you were even going to be on this panel, I was clearly, if not preaching to the choir, preaching to a soloist in the choir, because it seems to me that pretty much defines the arc of a lot of what you've done in both prior to that congressional testimony and since. It seems to me that's sort of the arc of your career, and what I would describe as a calling.
Well, thanks for reading your testimony and reminding me of that day. It was really moving to see. I think your wife was there also.
Yes.
um, and to hear the story of your family and your son, and um, you know, I'm sorry for your loss, and grateful for your service for really uh, uh, taking what I imagine is um, uh, unimaginable loss, and using that to make a difference in other people's lives through this radio show and the other advocacy that you do. And then, thank you for. It was great to reconnect. We reconnected, I think, maybe 4 weeks ago in New York City, and you reminded me of that day. And so yeah, thank you for that. As far as my own uh, motivation for doing substance use care, I I um, I didn't have any doctors in my family. It wasn't really a pathway that was something I had thought much about until I was in my towards the end of my college career. A I had a professor who was teaching a literature class, and he was a child psychiatrist. And he, in his lectures, he reflected on his experiences in medical school and as a doctor, and that got me interested because that was in the late '80s or early '90s, and I was interested in service. Specifically, I don't know if you remember this, but homelessness was actually a big issue, big social issue in the 1980s and 1990s. It still is. And where I was in college, there was visible street homelessness, and so I got involved in homeless services, and it was very rewarding work. I found that, like a lot of things you do that people do, I got more out of it than I put into it. And that was what, in the midst of having that professor, and whose name was Robert Coles, and that experience, my extracurricular experience in college, that's really what got me interested in considering medicine. So I had to do my pre-med classes after I graduated from college. I was a history and literature major, and that got me to the mid 90s, which was while I was in medical school. The medication uh, was developed that converted HIV from a terminal illness to a chronic disease. So I got to see before my eyes in medical school people who had lost many people close to them and were sure they themselves were going to die at a young age, really over a period of months to a year, see that they were going to live, and that was because of the medicines that they were taking. And so that was extremely inspiring to me, and I wanted to be part of that movement to help people, to treat people, to help them get their lives back. And then what I noticed in the midst of that was the differences between the people who had substance use and HIV and the people that didn't have substance use. And all of the advancements that we were developing in the 90s were much harder to access for people who were using substances. So what I would see is in the clinic where people would come on medication and see them, their lives get better, their health improve. That was contrasted with the inpatient hospital where I was doing rotations, and the hospital, even though we had treatments that worked, the hospital was still full of people who were dying of HIV and AIDS. And those folks were people who didn't really have access to the care and treatment they needed because of stigma, their own stigma and their community stigma, and most importantly, the stigma of the health system and the society in general that was really shutting them out from access to these life-saving and life-sustaining treatments. And so that's where I really made the connection with substance use and the stigma that was already around HIV itself, which as a society we were making progress against. That was doubled or tripled for people who were also using substances, and it didn't need to be that way. And so that was what really inspired me to think about doing primary care for people with HIV and focusing on substance use. Uh, and so that's what I did more training in. I developed some research interest. And in the midst of that, we're now in the 2000s. We started to notice these upticks in overdoses. And so I got involved in thinking from a public health perspective and thinking about how to address overdose through, through both better treatment in the clinic and also harm reduction, how to help people who weren't ready to stop uh, using drugs to stay alive and to try to live better. So you asked about um, training doctors to serve these patients better, and that has been a thread, starting with myself. I told you about myself, but my boss in 2011, my mentor and my boss, Volin, told me that we were going to start a training program um, uh, for doctors to become specialists in addiction medicine. And at that time, in 2011, addiction medicine wasn't a fully recognized specialty. And you just made a very strong case for why we need to treat substance use and addiction like other illnesses, and provide parity, which is what our session was about in 2014, um, to invest in both the science, the clinical care, and the training of the next generation of providers and how to provide evidence based and compassionate care. So that's what the movement around fellowship programs is, to train physicians. And obviously, physician training is not going to be enough. We need to really change the culture of the entire health system so that it becomes inclusive and open to people who use substances and welcomes them in rather than excludes them, which has really been what has effectively happened over most of our history. So, um, hold on, my email keeps going off. I'm going to shut it down so it stops beeping. Hopefully that'll work. Okay, so we started this addiction fellowship program in 2011, along with 8 other fellowship programs, and that was really the beginning of a movement to do specialty training in addiction medicine. Uh, and In 2016, the American Board of Medical Specialties and the ACGME, which is the Graduate Medical Education, the Accreditation Council on Graduate Medical Education, they recognize addiction medicine as a specialty equal with other specialties. And so that's where you start to get some indication that at least the so-called House of Medicine is going to think of substance use and addiction as illnesses that are in line with other illnesses because you're going to have a specialty care setting. So for 10 years or 11 years from 2011 to 2022, I was a fellowship director here at Boston Medical Center. And that was some of the most rewarding work that I have done in my life. Many of the fellows that I trained, well, all the fellows I trained are now leaders in addiction care. Many of them we have kept on here in Boston, but others have gone throughout the country where there are either leading programs or developing programs to improve care for people who use substances. Um, I'm going to do one plug, which is for the American College of Academic Addiction Medicine. I'm the president of that organization. If you're interested, you can go to ACAM.org and learn more about it. But we're the national organization that supports the development of addiction medicine as a specialty. And we try to support now. I said in 2011, there were 9 programs. Now there's over 104 programs nationwide, all producing the next generation of addiction specialists.
Now, when you say addiction specialist, are we talking about people that are certified in addiction medicine as well as perhaps other board certifications, or people that are just certified in addiction medicine?
Right. So the way it happens to be set up in the US right now is first you get a primary board certification. So for me, mine is internal medicine. So I'm a general internist. And then you get a subspecialty board certification in addiction medicine. So I have those two board certifications. The same is the case for subspecialties like cardiology or an infectious disease. You have to have a primary specialty in order to get those subspecialties. Now, um, addiction medicine is it's one of the few specialties where you can get a subspecialty in addiction medicine from any specialty. So surgeons, gynecologists, pediatricians, even radiologists. I don't know of any radiologist who's gotten a subspecialty in addiction medicine, but it would be allowable if they were interested. Um, and so, while you need a primary specialty, you can come into addiction medicine from any of the primary specialties.
Is there a preponderance of primary specialties where addiction medicine is?
Yes, yes. So it's I think the most common specialty is family medicine. And so there, if you are board certified in family medicine, I by the way, I'm very I admire our family medicine doctors because they are trained and board certified to take care of people across the lifespan. Um, but there aren't many subspecialties that are open to people who have a specialty in family medicine, but addiction medicine is one of them. And so we have that's one of the most common. The second most common is internal medicine, like me. There's more and more pediatricians, and we're starting to see an interest from emergency medicine. You were talking about the pit. You can imagine the pit would be a nice, better emergency department if they had an addiction medicine specialist who is also an emergency medicine doctor, because certainly every emergency department sees a lot of substance use. Um, or they could call on the addiction specialist consultant, which is how it works at our hospital. If we have an addiction medicine consult service, if they want us to see somebody who is in withdrawal or seeking treatment or needs help with harm reduction, they can call our addiction consult service and we'll come and see the patient and not just provide a diagnosis and treatment recommendations, but we're often equipped with we're lucky to have a multidisciplinary team. So we have a social worker and a wellness and recovery advocate who can really help with the social support of people while they're in the hospital and link them to services when they leave.
Well, that's quite a change from when we were dealing with my son in 2012. And I'm afraid it's still all too common in some places where I characterize the treatment as catch and release. Um,
That's right. And a term that's often used for short-term residential addiction treatment is spin dry, which is catch and release is what happens in emergency departments, right? They um, make sure the vitals are stable and if there's not an overwhelming reason to admit somebody, then they release them. They don't. Like you're saying, most in many places don't have access to either services in the emergency department or really are well connected to the community programs that they could link people to. And so that is just, I guess another term is treat and street.
yeah.
I don't know if you've heard that before, treat and street. But
Well, while we're at it, my son, when he was inpatient at what was then Roosevelt Hospital in New York City, um, also talked about people that would cycle in and out as three hots and a cot.
yeah, right. Yeah, it doesn't, it, we could do better. And some places are trying to do better.
I am one of the things that struck me when I was looking at your biography and stuff. It's easy to say Dr. Walley and you're an MD, and we all know what that means. But sort of hidden beside it, M.Sc, and it's like, oh, he got another degree. but actually yours is in public health, am I correct?
Yes, epidemiology,
Epidemiology,
which is
and it's
a public health degree. Yeah.
which seems to me is as as much a part of what your work is, or how your work balances out, or how you spend your time. It's divided more between the 2. Th those little letters at the in the that come after MD are also equally important. That's, I guess, what I'm trying to say.
Well, I really valued. I had the opportunity. Well, so when I did a fellowship, so that's a period of training after the residency. So to be a physician, people go to 4 years of college, then 4 years of medical school, sometimes right after college. In my case, I had got some life experience between college and medical school for 3 years. So then I was in medical school for 4 years. And then people choose a specialty and they get there's a matching process. And then they go for anywhere from 3 to 7 years for residency. I did a 3 year internal medicine residency. Um, and so then you're you're after a residency, you're ready to get board certified in a specialty. And I decided to do a little bit more training, and that was before they had addiction medicine as a subspecialty. So I did my training actually in research and for 2 years, and it had a substance use or addiction focus to it. But part of that was to get a epidemiology degree at a school of public health during my fellowship, and that's where I really learned my analytic and research skills in public health and epidemiology. And um, I think I value I value my time with my patients um, uh, a lot. That really underlies and drives both my curiosity and also the rewarding part, right? So it's extremely gratifying to have relationships with patients and to hear their stories. In some cases, see them get better. In other cases, um, uh, follow them through the progress of their illness. So that's very gratifying. Um, what the epidemiology doesn't directly help me with any of that. That's what I learned in medical school and residency. Where the public health and epidemiology helps me is to step back and try to see the larger trends of what's happening. And since I've been practicing, we've seen a lot happening with substance use. Really, a surge in overdose deaths, which before I could perceive it in my patients, I knew that there was these surging numbers of overdoses in the community. It works the other way. There are things that I hear about from my patients that aren't immediately um, viewable in the data, but then we look for them and we find them. So I feel very fortunate um, and have a lot of gratitude for having been exposed to both those sides of this of looking at the problem, or both of those perspectives, the patient level and then the larger um, epidemiological trends, or like in the most simple case for me, it's like the number of overdose deaths in the community in a year.
So, if I follow you correctly, when you're dealing with your patients, it's almost like you get some hints and some glimmers of what's gonna happen in the larger community, in the larger scope of things.
That's right. So when I can remember I had the good fortune to do a sabbatical um, from uh, July 2023 to June 20, sorry, July 2022 to June 2023. And when I got back, went back into the hospital, took care of patients, and we saw these terrible wounds that a lot of the patients who were in for injection drugs had, and they were attributable to xylazine, which was a new contaminant in the fentanyl supply that is now pretty well known in many parts of the country to cause unexpectedly severe wounds. And so it was seen first in the patients, and then we started looking for it at the health department um, through doing community drug checking. And now we can monitor the levels of xylazine in the community drug supply through that community drug checking, which is very helpful for people to know about. And then it really helps us with the education of the people who are at risk. There's still a lot that we don't understand about the drug supply and the contaminants, but by having this view on the front lines of patient care, but then also being able to collect and monitor data, that gives a really helpful view. I will say I stay humble because the drug supply is constantly changing. You may be aware or talked on this show about the fact that it looks like in many parts of the eastern U.S. That in 2024 there's going to be a substantial drop in the number of overdose deaths compared to 2023, a really substantial drop for the first time in a long time. I think that's what we're expecting to see in Massachusetts. And so that's all good news. I think we should take some credit and for that, but there's still way too many people who are going to die in 2024 and 2025, and I don't think we fully understand, you know, what it is that pushes these numbers up and down. So that's why I say stay humble and just keep bringing in the information that we're bringing in.
Is it cynical of me to ask that drug dealers might be modulating their fentanyl because they don't want to lose too many customers?
I mean, it's certainly the drug supply is a piece of it, but why they're learning that lesson in 2024 and they didn't learn it in 2023 or 2022 or 2021, I don't think makes, I don't think we have a good answer to that
Yeah.
because we've been seeing fentanyl in the drug supply since 2014 in Massachusetts.
Do you have, when you work in epidemiology, does the information you gather, is there any back and forth with law enforcement in terms of what they might do in terms of the drug supply?
Um, well, drug busts where there's a large law enforcement action, there's actually um, increasing research on this. The person who's kind of at the forefront is a researcher who was previously at Wayne State in Detroit, and then did a lot of work in Indiana, and now is in North Carolina at Research Triangle. His name's Bradley Ray, Ray. He's done some work on looking at what happens to overdoses when there are drug busts. And what happens is there's chaos in the drug market, even more chaos, and a lot of erratic change. What doesn't happen is that not everyone goes to treatment or stops using drugs when there's a drug bust, right? There's usually another supplier that comes in with a different product, which may be which is going to be different. And so it's that erratic piece that I think can lead to actually worse outcomes. So what would be great is when if a drug bust is going to happen, is that the local treatment and harm reduction programs be made aware at the time, and that people whose lives are disrupted by the drug bust um, could receive services that would help them if they're ready to go into treatment, and if they're not, then help them stay safe with harm reduction. So that's the type of coordination that I think is needed, and there's some talk of that. The CDC under the Biden administration was developing a program, and I can't remember the name of it, but it was essentially trying to mitigate the disruptions that occurred um, to people's neighborhoods when there were big drug busts that came in. Um, so that's some collaboration. Uh, the the Office of National Drug Control Policy funds what's called the high incidence drug trafficking areas throughout the country, and those are um, essentially coordinating centers for law enforcement on the regional level. And what they did about 5 years ago was maybe longer than that. They funded a public health analyst to be at all of these HIDAs. So they have an information officer and a public health officer at each of these places. And their job is to improve the communicate, first of all, the epidemiologic knowledge, so the collaboration and information exchange between public health and law enforcement, and then disseminate that. And so I do think that has had a positive impact in the sort of coordination between public health and law enforcement. Um, Another area where there's great partnership, which I had done a lot of research on, is what's called post overdose outreach. So, post overdose outreach is when somebody survives an overdose, but that overdose has been made known to the system through a 911 call, usually, or a trip to the emergency department. And then 2 to 3 days after that acute encounter, a public health, public safety team goes out to that person's house to see if they need support around keeping themselves safe or entering treatment.
Assuming they have a house.
Right, right. And so uh, that's exactly right. So that post overdose outreach is most active for people who do have housing. Now, um, that's an important group because folks that have housing um, may be isolating, or may they have a isolated place to use substances, and therefore, are at risk of overdosing and not being found. Certainly, people who are homeless have that risk too, but if they're in a congregate setting like a shelter or an encampment, that actually can be protective against a fatal overdose, right? Because there's other people around to respond if they get into trouble.
Yeah, no, that makes sense to me. I mean, when our son overdosed, he said, "I'm going to the living room to watch TV." And I went in, a friend of his called, and I went in to check up on him. And in that space of time, the heroin had done its work.
I'm so sorry. So he died at home.
No, he did not. I was able to get EMS. EMS arrived. Um, he had no heartbeat. When they arrived, they were able to get his heart going, and he was taken to the hospital. And he was six weeks in the hospital before it was determined that he was going to be consigned to a permanent vegetative state. And we attempted organ donation. He didn't die fast enough. He had a 1 hour time window once they took him off a respirator. He didn't expire then. He expired 24 hours later. And that's, as you know, and then we donated his body. We made an anatomical donation of his body.
Well, that's extremely generous and sounds like a very difficult um, time to go through. Um, I it does make me want to mention one of the things I'm thinking about now, because I've spent a lot of my time uh, focused on naloxone distribution, getting naloxone, the antidote to an opiate overdose, into the community and accessible to folks through making it available in pharmacies and without a prescription, and also making it available through harm reduction programs and other um, community access. But over 90% of the people who die from an opioid overdose, there was nobody there to witness their drug use or monitor their drug use. So that's 90% or more. Now, about half of those folks who aren't observed when they use the drugs, there actually is somebody nearby who's potentially a bystander. And this sounds like the situation where you were with your son at home. You were home and you did respond. and you actually were able to get his heart back going again. But ultimately, unfortunately, he didn't. It didn't work out for him. So one of the things I'm really interested in is figuring out how we can reduce the number of episodes of unmonitored drug use. Because if somebody's there at the time somebody uses and that other person is equipped to respond either through naloxone or stimulating them or doing rescue breathing, it's very unlikely that that person's going to have a bad outcome. Um, and so one of the problems, so I have had colleagues, close friends of mine who have died of overdoses where naloxone was right next to them, but nobody was there to administer it. And so a lot of what we focused on in the healing community study was naloxone distribution. And that works for people who are monitored or somebody else is present or somebody finds out soon enough to respond. But naloxone doesn't work for the majority of people who die from overdose because there isn't anybody there who knows enough to respond. And so, what are some strategies to improve monitoring? And one of the most sort of, I think, well known and evidence based are what people call overdose prevention sites or supervised drug consumption spaces. And those exist in other countries and now in New York City and Providence, Rhode Island. Of course, they shut down these places. They're not open 24 hours a day, but people are using drugs 24 hours a day. So while these are great, and there's tremendous resistance to these programs in many U.S. communities. So it's going to take a lot of work for them to be accepted. And even when they are accepted, it's not clear that everybody's going to go to them every time they, use drugs, because that would mean we'd need a lot of them. So another alternative is what we call, uh, uh, well, the one I'm involved in is called Safe Spot, which is funded by our health department and soon Connecticut and the Maine health department. So Massachusetts, Maine, and Connecticut. And it's a 24-hour, 7-day a week hotline where people who are going to use drugs can call on the phone. They get a hold of an operator who is trained and has experience, their own lived or living experience with drug use or overdose, and they will stay on the phone with them. And if the person becomes unresponsive, then they implement a rescue plan. Um, and so that often is calling 911, but it also can be alerting a family member who's nearby who may not know that person is using. So the family member can get there sooner. Um, and so this is a service that I think is very scalable uh, and has a lot of potential. Um, and we just need to figure out how to get more people who are high risk to use it.
It would seem to me might be very suitable for rural areas where people are. You call 911 and they're never going to make it in time.
Yeah, so that in that case, you got to help work with the person to have another plan, like to have somebody closer respond than 911, right? Because you can't deliver naloxone over the phone. Being on the phone with somebody just connects you with somebody so that they can alert someone else who is close enough to come by. Um, I will say that in every instance where the person's become unresponsive and they've had to activate the safety plan, the person has survived. So we haven't had any deaths on the Safe Spot line, and there's other helplines called Never Use Alone, and another one is in Canada the NORS line, and there haven't been any deaths on these for the people that use these lines. So that's encouraging. It's not to say it won't ever happen because of what you mentioned. It could be that somebody's so isolated that no one can get to them in time. But by talking to somebody who's an operator and making a plan, I think that really does lower people's risk.
Well, it seems to me that somebody wants to make a plan does have an interest in their own harm reduction.
That's right. So even that just making a plan, I think, helps people and reduces their risk.
When at Columbia 4 weeks ago, or however long ago it was now, you could you talk a little bit about what you did in Holyoke?
Well, I wouldn't say what I did. What I did,
What you
it,
learned?
yeah, what I learned, because yeah, what was great about the healing community study was that it was a community engaged um, uh, research project on a very large scale. It involved 67 communities from 4 states: Massachusetts, New York, Ohio, and Kentucky. And the communities uh, each convened a community coalition, and they got resources that they could put into addressing overdose. And one of the ones I highlighted was Holyoke, the community of Holyoke, which is an industrial city in central Massachusetts. Um, and what really impressed me about Holyoke is, despite the stigma that we encountered in many other communities, the community of Holyoke really came together to innovate around multiple programs at multiple levels. And the one I highlighted was their methadone clinic. So that community coalition was one of the few that asked for a new methadone clinic. And they asked for it to be placed in downtown Holyoke so people could walk to the clinic, and walk to the clinic, in less than 15 minutes. And that's because many of their overdose deaths are concentrated in the downtown area of Holyoke, where people where it's the population's the most dense. And they have other services there, but they didn't have methadone. And so they opened a methadone clinic, and people came right away. Many of the people were new people who had never been on methadone treatment before, and they obviously immediately lowered their risk a lot. Others were people who had gone to clinics that were far away, where they had to, make a choice between childcare and getting to the clinic, or taking the job they wanted and getting to the clinic, because the rules in methadone clinics are pretty strict. And so by having a clinic closer to home, it made it much more convenient for them, and probably easier for them to stay in treatment. Now, this clinic worked hand in hand with their local federally qualified health center that had a very robust buprenorphine program and harm reduction program. And so, you have people from different agencies who were working close together for the same goal. So that was also very inspiring.
Listening to you talk, I'm just I'm wondering, is there anything that um, families who have either somebody in recovery or families with somebody who's in active use, is there anything that families can do to help in the training of physicians?
Well, it's nice of you to ask what families can do to help physicians. We really need to, um, I think physicians need to do a better job of helping families. And I'll start by saying what I do when I really, when a patient's open to it, I try to include the family, because and when I think about people who've died from overdose, I recognize that that's obviously most traumatic to the person who died, but it's it's a huge hole and a huge loss for everyone, in that person's family. And so even before somebody dies, the the burden that the families carry is really, tremendous, and it's actually harmful to their health, and harmful to their happiness. And so the first thing that I teach our fellows when we're thinking about families is talking to family members about how they're going to take care of themselves, um, what they're going to do to stay healthy. Because of course, most families are focused on what they can do for their loved one, and I think that needs to include how they're going to keep themselves healthy. Um, and so that that maybe sounds easier than it is, but I do think it's really important to point that out to family members, that they can't, um, if they're going to really be there to help their loved one, they have to be able to keep themselves healthy. Um, then the other sort of thing is that this this illness is a conundrum, right? Because in very definition of addiction is people compulsively use despite negative consequences. So it's we call it a chronic disease, but it's also a learning disorder, meaning that even though people who have substance use disorders and addiction are very, very intelligent, they have a defect that's due to the illness where they can't learn from the negative consequences. And that's really hard for people who are in the family who don't have addiction to understand. And they want to blame somebody for that. They want, to blame themselves or blame the person they're trying to help. And that the blaming just doesn't get us anywhere, is the problem. So anyway, you asked me about what families can do for doctors, and I think what you're doing is a big help by being an advocate for parity and for higher quality care, um, to not settle, um, you know, to 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 advocate for better conditions, more investment in high quality substance use care. Um, some families have focused on holding corporations accountable. Um, I haven't really addressed it explicitly, but just going back to American College of Academic Addiction Medicine, um, it's important that organizations like them and others are free of commercial influence through because there's a lot of while I am a big uh, prescriber of medications that help people with addiction, the pharmaceutical providers, they have their own interests, and there's a lot of public mistrust of the commercial interests, because of the legacy of chronic opioid prescribing. So in our field, we need to be really tuned into that and make sure that the decisions we're making are what's best for the patient, and that we're not subject to commercial bias. So I just want to say that I don't know exactly how families can help us with that, except to be aware of it and to help, hold both the health system and the pharmaceutical companies we're all trying to do this a good thing, but we also need to hold up our ethics and make sure that um, you know people are getting what they bargained for.
I have, I've had a belief that because I've seen a lot of families, I've been in touch with a lot of families that have lost somebody. That a lot of I have a lot of hope. I have a lot of faith in grassroots efforts. People that have started a family foundation, people that have created recovery centers. Um, that is the small grassroots stuff that might be the one of the biggest hopes we have in the fight against addiction.
Well, I agree with you. I think um, one of the things I learned in healing community study, where again 67 communities in 4 states, 16 in Massachusetts, is that we know that some things work for sure. Like I can tell you that if you have an opioid use disorder and you take a medication, you're much less likely, FDA approved medication like buprenorphine, methadone, or injectable naltrexone. If you take one of those medications, you're much less likely to overdose and you're more likely to stay in treatment. But medication for opioid use disorder is not always enough. So I don't think everyone should have access to it who is diagnosed with an opioid use disorder, and we should make that access patient centered and low barrier. But that alone will help people, but it's not going to necessarily get people to where exactly they want to be. And to get people to be able to realize their dreams and aspirations, more is typically needed. And for some people, that's going to be counseling, psychotherapy, maybe it's a structured residential program, or uh, self-help like 12-step, can be very helpful. Re-engaging in their church and spiritual life can be very important. But all of those things need to be individually and I would say community tailored, so that they really work for that community. And that's where I think the smaller, like you said, foundations and family efforts, they should really focus on what works in their community, um, where they can have the biggest impact. Because um, again, what we learned from healing communities is if you have outsiders coming in trying to fix this, there's a lot of waste that happens in that case.
I hear you. One last question, because I know you have an appointment coming up. Uh, do you have any heroes, heroines? Who in your field has drawn your admiration?
Well, I'm
Besides
most inspired.
besides when you look in the mirror.
No, not when I look in the mirror. Um, I feel very humble when I look in the mirror. I have lots to learn. One of the things I love about this field is also the hard part, but you wake up every day, you see something different, and conditions are changing. And in some cases, we're getting new and better treatments, but how exactly to employ those treatments is, that's where some of the art of medicine occurs. But my heroes, for me, it does start with my patients. I just am really feel very privileged to be able to be part of their lives, to hear their stories, to bear witness to the tragedy and the triumph that they go through. Um, and what happened if people are alive, if people stay alive, which we're trying every day to do, most people get better. And that's a great thing. Um, so that's where I get a lot of inspiration. But then I couldn't do this alone. I have always worked in teams, and on those teams, there's a group of people that have different strengths, and we employ those strengths together. And I learn along the way. So I work very closely with a nurse and a case manager in my primary care program. We work as a team. I couldn't do it without them. It's Volsi and Aaron, in case you're listening. Um, and then in the research, I'm just really I have a research mentor. I have multiple mentors, but one who I've really worked with for many years, Jeffrey Samet, um, and and then there's the people that we've worked with in the training program. They're now leaders and they're on the cutting edge. I am definitely learning from them, how they're innovating to really meet the needs of patients that they're seeing. So I got a lot of heroes. I feel very fortunate, very privileged. Um, and yeah, um, yeah, we got a long way to go, but we've come a long way. And I think we're going to continue to make progress.
That's all we have time for the Kingfisher Project today. My guest has been Dr. Alexander Walley of the Boston University School of Medicine. Thanks for your time, Alex, and for helping us understand better overdose prevention, the integration of addiction in medical care. And thanks for your continued good work and your generosity with your time today. Thank you, Dr. Alex Walley.
Thank you to Bill and the Kingfisher Project. Appreciate what you're doing. Take care.